Hello, good morning. Welcome to our June edition of Implant Threads. Today we're joined by Ash Pandit, fellow MSc, class of 2023 alumni. And today he's going to be talking about autogenous dentin as a viable bone substitute for implant placement. A little bit about Ash. He graduated in India back in 2007 and then started practice in Mumbai. He's traveled the world offering his dental services on cruise liners. And then more recently, he's relocated to the UK, where he's worked in both NHS and private practice, and more recently moved fully into private. He, as I said, completed his MSc in clinical implantology with the University of Lancashire back in 2023, and is now a practice owner and has a real zest for education and research. And his little baby at the moment seems to be everything Dentin. So Ash, I'll let you take it from here. If there are any questions that participants have, please pop them in the chat and we'll do a Q&A at the end, and we'll see how we go. So over to you, Ash.
Lovely. Thank you, John, for a lovely introduction. It just took me back to memory lane, and just you made me really visualize all of that as a slideshow. But yeah, let's have a little bit of that. But good morning, everybody. So firstly, many thanks to VSS for creating this platform called Implant Threads. I think it's a lovely platform where you just get a diverse range of topics related to implants, and great job by John as well facilitating all of this. And I also have to thank the other members who are playing a key role in this. Firstly, Zemin, Alan, and Amy. So thank you very much for just giving me this opportunity. So it is something that you need to have it on a regular basis, just to have it as your implant sort of dose every month, every week, if you like. So yeah, here we go. So as John mentioned, that used to be my office. A little bit about me. That used to be my office. That's quite fascinating. Graduating in 2007, I was doing a private practice. I was running a private practice in Mumbai until a friend showed me, hey, do you want to work here? And my first thought was never as a dentist. So I thought some bartender, waiter, I don't know what he was on about. So, but then that seemed really, really interesting. So yeah, I said, let's do it. So if you can't see my office, I've got a close-up view of that. That used to be my office there. There's no dental chair. There's a dental bed, if you see. So patients don't sit, they lie, or maybe sometimes facing backwards and watching the ocean go by and stuff. So if you're wondering what I was doing, it wasn't mainstream dentistry. It wasn't implants on a moving vessel. It was some cosmetic stuff and pampering, whitening, and all of that stuff. But yeah, it wasn't mainstream dentistry. So that's me on the bridge of the ship many years ago, 2009. Yeah. So for those who don't know what a bridge is, it's an equivalent to what a cockpit in an aeroplane is. So that's the central console where the ship gets navigated from. And yeah, just nobody's allowed usually, but then I made friends with the first officer and I was given that opportunity. So there I am. But yeah, what happens on the ship stays on the ship. We won't go much into that, but yeah. So the journey from the bridge of the ship to a bridge on implants has been quite an adventurous one. Firstly, it was the ORE, quite a dreaded one, where you are to prove that you're a dentist in another country, and that's quite tasking. And just as you feel that, yes, you are a dentist, it is just being faced with a shock of the NHS. And then when you wonder, why are you even a dentist? And then you just go ahead, and as you carry on, just finding your feet, you're hit, the whole world is hit by COVID, and alongside then you do MSCs and courses, and then finally just upskill yourself with each day coming mentoring. And now a practice principal, another hat to wear, and that's quite difficult. Now I realize the other side of things. Dentistry is easy. Being this person is the most difficult one, as most would agree. But yeah, it's quite adventurous, and yeah, I'm enjoying. All of this couldn't be possible without any of, I mean, you would agree, without any mentor. So I think that's the most important thing. I've got many mentors, and a mentor is not somebody that you actually have a one-to-one learning from. It can be your colleague, just as a discussion over a phone or a case or something, maybe even a restaurant or something. But you just pick up those gems and, oh yeah, actually I need to try that. And then that's something that you call as a mentor. So the most two important people that have made me reach where I'm at the moment, and obviously believing in what I'm doing, is these two. This was, I think, a couple of years ago, John, if you remember, from the VSS conference that we had. So
Yeah.
you cannot not know this person, Fadi, the father of the organization, and never fails to amuse me with his ideas, with anything that he just has, like multiple ideas. So when I was introducing my topic to him, I wasn't sure how would it go down. He did his own research, and then finally sort of gave the green signal. And then you got Manoj, the crying shoulder. He can vouch for it. In my early days, he just go and cry about every little thing. Oh, the angle was this way, could talk this way. So to the extent that he must have almost given up. But yeah, and now we work together and run this place, Priority Dental, where we run the MSc programs for implant dentistry, and now we've also started the advanced level 2 residency program. We might just have more batches coming up through the year. But yeah, that's where we all do what we do day in, day out, mentoring and clinical supervision and stuff. So yeah, that's guys. That's a bit about me. Good morning, everybody. I'm Ashish Pandit, and my topic for today is autogenous dentin graft, a viable bone substitute. So what we expect to learn from this today is to describe the rationale of ADG, the autogenous dentin graft, the efficacy, what it has to offer. Are we in comparison with the conventional bone substitutes that are available for our everyday implant dentistry? And lastly, describe the process of a chair-side fabrication of the graft material, and how do we actually put it all into perspective, just diverse clinical implications. So my favorite treatment till date has been an extraction out of all RCTs. I mean, some might just find a pleasure in doing a complex curvy root canal or something. For me, it has always been an extraction. And I hope for an implant dentist to do what the job. I think it all starts with your surgical skills, and the least that you can sort of practice into getting surgical stuff is your extractions. And I hope to do it this way. And I've tried a lot of other things as well. And my American colleagues, so some of my friends from my uni, have now moved to the US. And this particular instrument, a physics force, was quite famous there, the Goldman Fox Company or something that is called that. And they actually swear by it. I've tried it a couple of times. It just didn't work in my hands. And the whole concept of doing it in a very buccal fashion is not something that I was fundamentally aligned with. For me, it was just more like a very delicate procedure, just so that now that you're thinking about implants, you've got to just maintain the bone, and it's all about the bone now. So yeah, I finally gave up on this. I did try this one, pure engineering miracle. Never fails to amaze me, but it's a bit of a setup that you need with this. It's that's the engineering thing, that the whole tooth comes out vertically, and yeah, it's less traumatic and basically supposed to not make the patients feel anything about it. All of this otherwise doesn't work for everybody. So if it's particularly a Friday evening, and say for example your nurse has got a date or something and you're running late and you break a tooth, I usually resort to this. So that's typical. Everybody must have been there. But yeah, but regardless, whatever you use, what happens is the tooth finally gets down to this little box. And that is where we start thinking, is that actually a clinical waste? Do we really have to discard it? Or can there be anything that you can do with this tooth? Sometimes I've seen cases where a tooth is decoronated and just hollowed from inside. You can use it as a shell. There's some use for it, sometimes used as a temporary by splinting with a composite. And now we're more into the implant world of it. Now we're just thinking everything about the bone. As they say, bone sets the tone. So it's all about the bone. And which is why we're just thinking, can there be any best use of this tooth material? Which is what brings me to the topic of autogenous dentin grafting. So I've always been fascinated since uni days about definitions and stuff and never really got them right word by word. And that's how we used to get marked on in the uni. So I don't know, for some weird reason, I was fascinated by just creating my own definition. So I thought this was the best way to really describe what that means. So I'm just going to read that out word by word. So that's a process where extracted teeth are physically and chemically processed to obtain a disinfected particulate biomaterial that can be utilized in the same patient to perform bone augmentation in a way similar to conventional biomaterials. So the key word in this is it's the same patient. It has to be used in the same patient. So we get more into that. So when we talk about conventional bone substitute materials, are most widely available materials can be an allograft. Now I've heard difference of opinions in using an allograft versus a xenograft or a synthetic biomaterial. So allograft proponents would be in the favor of using that much more because then it just gets converted into bone and doesn't stay as a dead cementish material in the body like your bovine xenograft, which makes sense in terms of theory, but there are other things to that what the other biomaterials have to offer. So the next one in line is your widely researched, and the ITI has a lot of articles, and obviously all of the authors and followers of ITI would mostly be swearing by BIOS. Danny Boozer just spent about more than 30 years in doing GBR and everything about BIOS. So it has its own place. Volume is maintained and it's extensively researched. It just doesn't disappear because there was interestingly a case that we used the allograft into the sinus to do a lateral lift. In about 8 months' time, when you usually do the CT scan again, I was absolutely amused to find the sinus completely empty. And I'm still wondering, and that has never ever happened. And I'm just wondering what actually happened to the allograft. Has that been completely turned over? But then it should be taken over by something else, which is the bone, ideally. That's what you would expect. I don't know. It just didn't work in that particular case. Not that I'm talking down about allograft, but that's was one of its properties there. Maybe it just turned over rather quickly and nothing was left. Ethos or the beta tricalcium phosphate are synthetic biomaterial. It has its own place, doesn't like pressure, or you can't just compress it against something. Maybe works in defined areas like an extraction socket or a vertical defect, or maybe like a veneer graft and it sets, it's biphasic, doesn't need a membrane. So it has its own place. So all of these materials have their own place, and careful case selection is paramount. And it has all been extensively researched. So in comparison to that, we're thinking, have we got a tooth which could potentially match the efficacies of all of these biomaterials and still turn out to be a viable bone substitute material? And that's what just brings us to the why of it. Why do we do what do we do? So it's the rationale behind that. It's developed from the same embryological origin, which is the neural crest cells of the first pharyngeal arch. So if you really remember your year one dental anatomy. Don't know what's there in the UK, but then we had it on a second year dental histology, where you see the neural crest cells, the dental follicle, the dental sac. It's all, so the bone, PDL, and all of that is from the same origin. So chemically, embryologically, it's all similar. I won't say same, otherwise it would have been the same tissue, but it's similar because the origin is the same. Like how you have your ectoderm, which is the same, hair, nails, and stuff like that. So it's similar in its origin. The dentine matrix of human teeth shows presence of BMPs, the trigger point, the spark of osteoblast differentiation. So if you consider your osteology theory of how the undifferentiated cells get stimulated to get differentiated into osteoblast, then osteocytes, then bone matrix is laid down, bone formation takes place, and we also need the osteoclast to have a tab on all of this. So that's where the BMPs come. So typically it's the BMP 3, 4, 7, which are fundamentally essential for bone formation. There are a lot of other BMPs which have a role to play in organ formation, but then the ones which are of keen interest to us in this particular topic is the one that forms bone, particularly the alveolar bone. And finally, the human teeth and alveolar bone, being hard tissues, are similar in chemical composition as well. So if you were to elaborate more on that, we've got the like for like comparison between bone and teeth. So you've got almost 60 to 70% of mineral content in both bone and teeth. Collagen, which is a fundamental element of any bodily tissue, you've got 30 to 25%, again, a similar proportion. Water, more or less the same, and both of them, bone and teeth, have BMPs in it. So far, considering all of what we've got, if we have to really think, is that still a viable material? Is that comparable? What do you think? So the first thing when I was in a way introduced to this topic was a bit of a story. I was doing an extraction. I'm sure everybody breaks teeth and some of them are not able to be removed. And I happened to see my own patient where a small piece of tooth, the apex of a premolar, I think it was an ortho extraction, was left behind. And I happened to see the patient in a few years' time for an implant placement. And when we did the CT scan, I particularly remembered that yes, we had broken a tooth there. And then the scan was just not showing that tooth anywhere. And that just triggered something. And the concept, the phrase for that was replacement resorption. And that's really key to this whole topic because it's replaced by something and the main material is eliminated or resolved. Or that's something that you may even see that just doesn't show on an x-ray when you try and look for it. So that's what it is. So which is why we go more into it. We just deep dive into the whole literature of what has it got to offer to us in terms of an actual scientific evidence or a backup. So this dates way back in 1960s, 1967, if you see. The first proponents were Yeomans and Urist and Bang as well. There was another scientist to this thing as well. There were multiple papers for all of these, Yeomans, Urist, and Bang. So this particular paper defines the presence of BMPs in human decalcified dentine. And because there's a presence of BMP, it is quite right or probably to consider it as a fact that the human dentine matrix has an osteoinductive potential. So the next research, if you just fast forward it to many years, 2013 all the way, Kim et al. Did a similar research and really took sections of teeth, histologically studied them, did multiple case series and reports on different clinical scenarios and sinus grafts and placed implants in about literally 5 or 6 months of the sinuses being grafted with the Dentin graft, and the implants have been reported to be successful. So once again, it proves that it has an osteoinductive potential. So if we go down into the histological section, so obviously seeing is believing. So when we actually see it under a microscope and define the individual tissues, this study particularly shows us that there has been a frank presence of both materials right next to each other. And if you see the slides, so this one is a 200x magnification when you see the dentine granule marked as X, and then the pink material surrounding the entire granule is the bone, newly laid bone matrix, and all around the granule. So if you super zoom it about 5 times more, which is 1000x, you might see something like this. So there's a demarcation between the dentine granule, which is this line, and then the surrounding matrix of bone. And you can see this as the dentinal tubules, which are showing through this area. Again, this was in 2021. Once again, that shows the active bone formation around it. Now, if we have a like for like comparison in this area, we compare it with our gold standard of bone grafting, which is the autogenous bone. It can never be replaced by anything because it's still bone. It's just the trigger point of where you get it from, and finally has osteoinductive, osteoconductive, and more importantly, osteogenic potential. It's got live bone cells. Nothing can be in comparison to this. But if you really see this study, all of these sites were treated with alveolar ridge augmentation. And if you see the clinical ridge width gain 6 months after augmentation, this study showed an increase in the sites treated with a dentine graft as compared to the autogenous graft. And that difference was statistically significant. And this wasn't a case report or a case study, it was a randomized controlled trial, standing quite high in the evidence pyramid. If we go further more into it, instead of using dentine as a granular material or as a particulate material, you can use it also in the form of a block, and that can be used as a block grafting as opposed to a block harvested from the ramus or something. So that again showed less resorption than the autogenous bone graft. Next one is our favorite bioos, mineros, which is a blend of cortical and cancellous bone. So in theory, it just gives you a perfect combination. You just have the cortical element to represent the cortex of the bone, and then the cancellous bone to represent the cancellous part of the bone. And then perfect, it's from the same species, and everything's just perfect in theory about this. So when you have a clinical study, it says the demineralized bone allograft, and when the dentine graft has been compared, the dentine graft shows a better preservation of the ridge dimension. Also, if you have a randomized control trial, it shows less reduction in the ridge dimensions a few months later compared to the allografts treated sites. Again, quite a statistically significant difference in both. Next is again an extensively evidenced material. Both sites treated with different materials. And you see a difference where the dentine grafted sites exhibited less reduction in the dimensions compared to the xenograft. Also, this study showed that the turnover rate of the dentine graft was much faster than the bios treated sites or the xenograft treated sites, which just shows that when you are going to re-enter that site to place an implant, you're actually having bone as opposed to a dead material which is just staying there as a scaffold to form new bone again from the host. So that's again quite significant. Similar to this is ethos, again osteoconductive like the xenograft, and then they exhibited less reduction in the ridge dimensions for the synthetic graft treated sites. Again, a randomized controlled trial, so quite high on the evidence right over there. Now, this is the father of all studies, a systematic review and a meta-analysis of all the randomized controlled trials that were done. And that's quite recent. This is a 2022 paper wherein the results of all of these studies, this study particularly, the systematic review, it said that the Dentin graft is an effective option for bone augmentation around dental implants with acceptable stability, marginal bone loss, and incidences of complications and failures. So, in a sense, what it tries to say is it is a comparable material wherein the success is similar, if not higher, which in fact is proven to be higher, but at least it's not lesser. And also, it is having the same or similar incidences of any bone loss or complications and failure. And that again is a subjective phenomenon. It depends on person to person. Another study to back this one up, if we deep dive more into it, the recent research, this study is again a systematic review and meta-analysis done just 4 months ago, Feb 2026. Quite a lot of factors to be compared in this study. So they produced significant new bone formation compared to xenografts. The grafts were resorbed completely, leaving less material behind. And the dentinal graft showed comparable stability to heal naturally and dramatically reduced the bone loss and the ridge dimensions. So, all in all, it supports the whole rationale of using a dentine graft as a viable bone substitute material. So, clearly, if we consider all of the findings, the clinical cases, the research that has backed this up, I personally feel the balance is steering more towards the tooth. If we understand why we do what we do, we can just delve in deeper into how do we actually obtain this dentine graft material and what are the different ways to procure this and where do you actually send this to get that into your hands. So there can be two different ways. You can either send it to a tooth bank, which is a dedicated institution wherein teeth are labeled and sent to this place. They are being processed, converted into a viable, usable bone substitute material and sent back to you, which is the tooth bank. Or you could just do it chairside yourself. So there are two different methods to do that, two different machines to do that. One is a tooth transformer, and the one that I use quite frequently now is the smart dentine grinder from Cometa Bio. So if we go into the first one, which is the tooth bank, which is a dedicated institution based in Korea, which is where you send your teeth in an ethyl alcohol storage. So it maintains the chemical composition similar to when it was extracted. Then at the back, what happens is there's a process where they separate the anatomical crowns to actually obtain the raw root material, which is then shaved off to obtain a raw dentine product. If you take the cementum off the roots, what's remaining behind is the dentine, and right in the core is the pulp, which is an organic substance. So once that has been obtained, you grind that down into a powder of 400 to 800 microns, and then it's been distillized. And then the process starts of actually processing and then just getting all the organic components out. Dehydration, heavy, extreme dehydration to save that into a transportable format sent back to the dental practice to be used. Now, obviously, if you use that, it's a dedicated, standardized, factory-made product. So obviously, it's got its standardized process. The protocols are all there. And the downside of that is it has got to be sent all the way to Korea and then returned by them, which may take a long time. So the whole process, the ethos of doing an immediate implant is no more an immediate. So obviously, you have to take the tooth out, preserve that biomaterial, then maybe used as your GBR case or something like that. Unless you take a tooth out which is not going into an implant site. For example, a wisdom tooth or another tooth which is wobbly or has got to be extracted for some reason, like a vertical fracture or something like that. And then if you're using it as an immediate, yes, it can by all means used. So the next one, which can be done chair side, is the tooth transformer. It's fabricated in Italy, so that's where it's being made from. So the difference here is that you take the tooth out, clean the tooth for any caries or restorative materials, any internal material as a endodontic filling, and then the tooth is inserted into this machine. The chemical solutions which are used to let the tooth undergo that sterilization process is the solutions are inserted into the machine, and all of it is an automated process. You put some stuff in there, the tooth and the chemicals, and off comes out the usable graft. The advantage is it's all automated, so there's no human element to it, and thereby no subjective errors. So no cross, or rather less cross contamination, because all of that is a sterile thing, just put it in. But then the initial cost of setting all of this up is relatively high than the device that I use, which is the smart Dentin grinder. So this is an American based company, Cometa Bio, and the extracted teeth are cleaned. All the PDL has been removed from the roots. You take the restorative materials off, or any debris or anything which is there, just remove that. The teeth are now placed in this single use chamber. So this part that you see is a detachable single use chamber. Now the FDI in America deemed this material as a non sterilizable material, and hence this is going to be just used only for one patient. What you can do is, if you expect a patient to have another implant or some treatment in future, you can just give this back to the patient to take home, keep it. If he ever has a tooth extracted in future or requires some implant treatment, he can just bring this back. And that's what I do. Rather than just throwing it away, you may as well just give it back to the patient. Who knows, you might just need it because anybody else is not going to use it anyway. So you may as well. And this machine is otherwise, literally, as the name says, is quite smart. So as soon as you just turn it on, the chamber is still not ready. So if you see this, because there's a dedicated clicking locking mechanism for this, because it rotates at such a high speed that it might just fly off. So unless this is securely locked, the light won't turn on, the machine won't just work. And you see these two components here, that's where the ground material is being separated into particles of different sizes, and one which is below 300 microns, and the other one, the top one, is like a relatively larger particle size, which is 300 to 1200 microns. And then if you need, you could either mix them into like a common pot and have a combination of large and small size particles. It's still the same material. It's like your bovine xenograft. BIOS typically has an option when you order. Do you want large granules or small granules? And depending on the case, you just choose that, right? So you can just choose that similarly in this case as well. So once you transfer it into a sterile container, the particulate material that we've just pulverized into this chamber is now undergoing a chemical treatment to obtain the disinfected bone substitute material. So that's the disinfected protocol. So up until now, it was the physical process. You physically drill the tooth, grind it, obtain the pulverized material. Now starts the second phase, which is the disinfection protocol. So the particulate material is collected in this sterile container. So when you order it from the company, all of this is vacuum autoclaved and sent back to you. And you could treat this with the Dentin cleanser. That's what the first chemical that we use. So it's the red capped bottle, wherein it completely covers the material and is left undisturbed for about 10 minutes. Once that's done, you just remove the solution with a sterile gauze, and you've got a moist pulverized material there. The next bit would be in anyone's mind, what exactly is this material? How does it do the actual disinfection process? So this material is basically a 0.5 molar solution of sodium hydroxide. and it is mixed or delivered in a 20% ethanol as a carrier. So the sodium hydroxide is a highly caustic material, highly alkaline material. It's got a pH of 12.1. And this is the fundamental principle of removing all the organic debris and the bacteria from the dentinal tubules. So if you consider your endodontic treatment for the time being, we use calcium hydroxide into the canals, right? The principle or the mechanism of action is it's highly alkaline. And that's why when we are doing two visit endodontics, you open up the pulp, debride everything that you can, and then dress the tooth with a calcium hydroxide solution. If you see the periodic table, it's all under the same row anyway, which has got the same valency and it's from the same group. So the alkalinity of this material is what the key ingredient here is, just to disinfect everything. And that's how it actually takes away all the unwanted material from the tooth. Because of an actual crushing action of a tooth, BMPs are actually known to release. So the previous paper that we shared from Kim et al., they actually crushed the tooth in that particular study to expect the BMPs to be released. And if I extrapolate that principle from that paper, it just makes more sense now. When we are doing a very, very difficult extraction, you're crushing a tooth and some particles are just being released. Some of it you can actually visibly remove, some of it it's not come out, but it's not even being seen. And then if you see a few years later, like I was saying in that example, you just don't happen to see it. And that's when the BMPs are actually crushed and released into the local environment. And now if that's been encouraged to be a disinfected material, it's all the more good for us. The next step after taking away all the dentine cleanser solution is to now reorganize the pH to a physiological level, which is why we've got the buffered saline solution. This process is similar to the previous one wherein you completely immerse the pulverized material with the solution. Leave that for about 3 minutes and then just repeat the process. Just in case if the first cycle wasn't enough to remove anything which is too caustic, you might as well just do it once again. There's no harm. It's still ethanol. If it is adjusted, it won't do anything at all anyway. So there's no harm in redoing the step. And the clinical protocols from the manufacturer, I actually recommend you to do this process twice. So like the first cycle, you remove the excess green solution with a sterile gauze. And there you go. What's remaining behind is a particulate dentine, which is now ready to use and which is similar in its handling properties to a saline mixed bovine xenograft or your allograft, and pretty much the same uh, adherence to the instrument or to the bone, and basically all the handling properties are the same. So the advantages of this particular process is that the expense of all the instrumentation and the overall process is relatively less as compared to another comparable chairside graft material fabricator, which is the tooth transformer. And the graft is obtained in about 15 minutes. All you need to do is just 15 minutes. Once you know the whole drill, it hardly takes 15 minutes. So much so, in one of the practices that I work at, the nurse does the entire fabrication for me. And she's very good at that because she's got the whole concept of the sterilization, what should be touched, not touched, and it actually makes it quite easy for me. So whilst the tooth is out and the implant's being placed, because the first thing that I want to ascertain, especially in an immediate, is to make sure that I've got adequate primary stability. So once I've made sure that the implant is actually being placed in the correct place and it's got sufficient stability, now I know for a fact that the implant's not definitely coming out today. So we're not aborting the procedure. If I've got to do anything else, or maybe just give a patient a break, or maybe sometimes I do a soft tissue grafting, especially for anterior cases. So as I'm harvesting the connective tissue graft from the palate, and de-epithelializing it, and that takes about a good 10-15 minutes, stopping bleeding if there is any in the palate. My nurse alongside is preparing this for me and it's all ready. So as soon as the graft has been secured, in goes the bone substitute, and that's it. It's all ready. The disadvantage or the downside, we would say, is it requires some steps to chemically disinfect, and therefore there is a small element wherein human errors could be introduced. It's up to us. I mean, then that's something which is similar to as simple as your surgical setup. You might just do a fantastic implant placement and bone graft and stuff, but then your surgery setup itself was awful. There are nurses who just don't have a clue of how it is to be done. And so all of those factors still have a cumulative effect on an overall treatment outcome anyway, right? So that's something what I would personally attribute this to. So once you standardize your protocols, that to me, although yes, in theory, a downside, it is a manageable problem. And so far it has been working quite well. Now, if we actually see even more into a critical standpoint, does the Dentin cleanser actually work? So there was another study done by Girardo and Lanka and guys. So where they actually used the Dentin cleanser or the sodium hydroxide as a material to test its efficacy against a range of bacteria. And then the conclusion was if you demineralize it or chelate the whole thing using EDTA, it seems to be an effective disinfectant method, particularly against organisms like E. coli, P. gingivalis. Now, this is particularly in perio cases that we see E. faecalis, and there have been more studies. If we actually see the cultures, these petri dishes were inoculated with the bacterial samples, and if one of the petri dishes were treated with the same solution, 0.5 molar sodium hydroxide, and you can see a distinct area where there has been no bacterial growth as opposed to all the other areas here. So that in a way, once again confirms similar to the histological appearance that the solution actually prevents bacterial growth and is as clean as it was before. If you see the commercial industry where they see chromatography stains and other systems and stuff, they have done studies using sodium hydroxide. Again, now this was just 0.1 molar solution of sodium hydroxide. What we're using is 0.5 molar. They did it against different titrations as well. It was shown to be active against viruses and prions. The one that we were particularly worried about with the Creutzfeldt-Jakob disease or the mad cow disease, that's what it's called as. So that's shown to work against viruses and prions. Bacteria, yeast, and fungi, a lot of studies with that, endotoxins and exotoxins. So all in all, the whole concept of using a highly alkaline solution is just proven by the study. So the clinical indications would be obviously, like I mentioned, an immediate placement wherein the jumping gap, which is the gap between the buccal surface of the implant and the palatal surface of the buccal bone or the socket wall, that gap which you have is to be grafted. Some people advise not to graft that at all, let the blood clot form itself, but more likely than not, just to maintain the contour, grafting is normally, usually, generally recommended. You could use that in partial extraction therapy or the socket shield technique. So you just take the socket shield, for those who don't know, is just where you take the entire tooth out, leaving behind the buccal surface of the tooth so that the PDL is still maintained, thereby the bundle bone is maintained, but then the jumping gap still remains. Sinus augmentation procedures, guided bone regeneration as a veneer graft, ridge preservation. So if you want to do a socket preservation or a socket grafting as it's called rightly, that can be done for a delayed placement. I've had some patients where I've done it for pontic site maintenance. The tooth was kept as a backup plan in case one of the distal implant fails. I don't want this side to completely collapse on itself. So you could either take the tooth out because it's needed to be taken out, but you can still maintain that site for a possible future placement. That's similar in theory, in concept, to what the root submergence technique. You do an RCT, decoronate the tooth, and then just submerge it below the bone. The fact is it still maintains the ridge dimensions. So you could just in fact take the tooth out if it is indicated, and you may as well graft the socket and just maintain that thing. And it's not just as a backup plan, it'll also aesthetically give you a good contour if it is in the anterior area without you having to do a GBR in the front region. And now, if you have to do an extensive GBR, now you're looking at possible soft tissue grafting and free gingival grafting just to maintain all of that stuff. Now, that comes with some aesthetic issues and so on. The other areas where you can use that is in periodontal regenerative procedures, treating intrabony pockets. And what I've also particularly done and found good results with is after extracting a wisdom tooth, an impacted wisdom tooth, where you've got to take the bone away. But if the tooth is at an angle leaning against the distal aspect of the seven, where it typically resorbs the cervical part or maybe the root area of the seven, you are likely to encounter a poor adaptation of the gums there because it's already been eaten away. So to not have distal pocket or recession, what I've done in the past is taken wisdom teeth out, ground them, put them into the socket itself, and then just have a beautiful closure, and just reduces the sensitivity, the post-op sensitivity in the seven, maintains the periodontal architecture, and prevents any pocket formation, and basically just takes down all the issues. The advantages of this material and particularly this system that we use is that it's biocompatible. So the communication with the patient is quite easy. At my very first grafting procedure, when I wanted to tell the patient that I'm going to do this procedure to you, use your own tooth, recycle and put it back into yourself, I was having inhibitions. But then surprisingly, the patients really accepted that quite quickly, as opposed to when they ask questions about where do you get the bone from when you're talking about bovine bone or human bone. And the moment you say that it's from cadavers, and obviously you've got to reassure them that it's all sterilized, not straight away from the crown and everything. But and it goes down as a joke, but then they still do question that. With this, I've typically notice that they just don't have any questions. What happens to this? How does that work? So and they're in fact more intrigued towards it. So my communication with them was much slicker with that. So and more than that, the communication aspect, it's the overall acceptance. It's their own tooth going back into their own body. Who would want to reject that? It's osteoinductive. It's got presence of BMPs, so it's proven to be osteoinductive, which the other products are not. So they just stay there as a scaffold. Now, the resorption rates might differ and really guide their clinical implications, but they are still osteoconductive more likely than not. And this material, Dentin graft, is also osteoconductive in addition to being osteoinductive, which also lends its support in forming more natural bone rather than just stimulating the natural bone. It also acts as a scaffold itself. It's easily prepared chair side within 15 minutes. It's comparable when it comes to its handling. There's nothing special delivery system or anything that you need. So when we are talking about dental materials, you've got to have like a carrier or something. As you would use a normal biomaterial, you just use it the same way. If you are not sure, and potentially sometimes patients are not even open to the idea that, yeah, I might just have an implant or might not, I'm going to have my research done and sort my finances out. Fine, that's fair play. You can just take the tooth out for that instance because it's indicated. Or if there's an active infection, let's say there's a draining sinus. So it is otherwise contraindicated to do an immediate placement when there's an active infection. So you still take the tooth out, but when you are going to do a placement later on, you could just use the same tooth. Some studies, especially the one with Kim et al., they had done this research on cadavers which were excavated in during archaeological studies where the cadaver bones, the skull bones, were pulverized. So obviously they were fossilized and they were pulverized, and they still found some BMPs into those cadaveric teeth, and that was quite a important study. It just basically goes to show that the BMP stay in the teeth for a very, very, very long time. Basically, it's a part of that. It just has to be unfolded. When it comes to the autogenous, if you're really comparing it with the gold standard bone substitute, or the bone graft rather, No additional surgical site is needed, thereby reducing patient morbidity. You're not having the ramus open or something else, the anterior nasal spine being scraped. The whole scraping action is not sometimes liked by the patient. Or maybe even when you describe to them, oh, you're going to be scraping my bone. Oh gosh, I don't want it. It's just there, ready for you. Patients have reduced apprehensions about where it's coming from. Some of my patients are vegan, some of them, because of any religious reasons, don't want to use bovine or porcine bone materials. And as opposed to the commercially available materials, this is less expensive, relatively affordable for patients who are not ready to spend that much on a bone graft. So they're okay with the concept of an implant in principle. The moment you start making a treatment plan and say, well, the bone graft would cost X amount extra, oh, now I'll have to rethink. So that might just be something which might be working in your favor in terms of doing the treatment correctly, still keeping the price down, and all the other principles are still exactly the same. The limitations would be a tooth needs to be there to be used as a origin. You can't produce a dentine graft without a tooth, and that tooth needs to be indicated for an extraction. So if it's a healed site, a patient comes in after about 10 years of a tooth being lost and there's nothing else that needs to be removed, unfortunately, you can't use a dentine graft. It has to be used in the same patient. That's why it's autogenous. Surprisingly and interestingly, at this stage, there was a study by Joshi et al. Where they did a research on the tooth extracted from one person and pulverized it, exactly made it into a dentine graft, but used it in another patient or maybe a series of patients. But there were some more research required on that. It still, the conclusion was still that it gave comparable results, but obviously ethical approval and more microbiological research in terms of the DNA or the genetics involved into the cross usage was to be unfolded, unraveled. Hence, it's not that popular yet, and which is why I haven't included that in my literature review, at least in this presentation. But yes, research is getting done in that aspect as well, because you might just use a tooth from one person, literally use it as your allograft and use it in somebody else, the principle being the same, but obviously it comes with those cross-contamination genetic issues and so on. If the tooth has been decoronated due to or treated physically due to an extensive amount of caries, what you actually get in return might be far less than what you need, in which case you may still have to resort to your conventional biomaterials anyway. Maybe use it as a mixture. So use, say, 40% of your dentine graft and the remaining, say, 40% as your autogenous if you can harvest, and you should ideally, and the remaining 20% something just to make up the bulk of it, whatever is needed for that particular clinical site, you can just use your allograft or xenograft, which I've done in one of the cases as well. And that's still, so basically, in my mind, if I was to really break it down, my dentine graft was being supported by my xenograft. My autogenous bone was supported by my dentine graft, and then the autogenous bone is just going to form there anyway. So it has worked and given quite good results as well. So if we go down to the clinical case, this was the very first case when we did, which is why I've just put a brief background of what the patient was. So age wasn't on my side. This patient, but was taking amlodipine, but then was not really open to the idea of an implant in the first place. Then when we spoke about the bone graft and everything about it, as you do in a consent, she was all the more worked up with the whole concept. So it was quite a difficult case to really accept as your case. Then we went to the SAC classification. It was complex in terms of surgical because it was an immediate placement. She had a deep bite and quite a heavily filled restoration in the mouth. So generally complex. Aesthetically quite advanced. It was an anterior case and fairly straightforward. So if you see this case, it was an upper left one, a broken tooth right in the front, and also a missing canine here. Occlusal view. just couldn't be saved. The tooth was taken out. We did a guided placement for this just because the patient was extremely nervous. We didn't want to take our chances in terms of the angles and everything. Just go there and get the job done so that more of the time could be spent in the grafting and the other processes. So got a good placement, good top. And then once that was confirmed that it was all stable in the correct position, now starts the whole process. We, because this was an endodontically treated tooth, we went straight down into the root chamber or the root canal, split the tooth vertically. The GP point was removed, the sealant was removed, any unsupport like the dead material that was found, or maybe a slightest amount of doubt, because some of it was affected dentin, which is otherwise okay. It's not infected, it's only affected. But then any chance where you feel that it might be a bit decayed was just removed and then inserted into this single-use chamber. Once you place it into the chamber, you seal the lock with it. That's how it looks, and the tooth is now in. And here we see the actual process. That's it. 3 seconds, and you can see the tooth has been pulverized there. If on occasions I find that the grafted or the particulate pulverized material is a bit bigger in size, you could just repeat that process a couple of times. There's nothing that's stopping you from doing that. It might just grind the already ground material, just make it into much finer particle size, and that is fine. Once the grinding is done, we've got to have those pulverized materials coming out of these little holes into this filtered chamber there, which segregates into particle sizes of less than 300 microns, which is in the lower section, and of higher 300 to 1200 microns of the upper chamber. So once you grind it, so that vibrates the particles and gets it down to this chamber. And now you can see the particle sizes. If you want, you could just put that back into the chamber, grind it again, get it much finer, and then just use that. Transfer that into the sterile dish that was supplied by the manufacturer, and then just transfer it over. Now you treat it with the chemical protocols. First one is the Dentin cleanser. You can keep that for 10 minutes, cover it up. After 10 minutes, just get that solution removed with a sterile gauze. What's being next as a step is the buffering action. You're going to manage the pH. Just get that into the Dentin dish or that bowl. Removing the excess solution, repeat that again, and the graft is ready to use. Now is when you insert into this, you can use the dual zone all the way up to the marginal gingiva, and then have a bit of a soft tissue augmentation if you have to, if the phenotype needs some alteration. Secure that in place. You can either make a temporary crown, which is to be kept ideally out of occlusion. If not, if the occlusion doesn't permit that, you can just have a simple customized healing abutment. That's out of occlusion. What I like is just the contours being maintained, and then it's all out of occlusion. Leave that undisturbed, let that cook. And alongside, what I did in this case was just placed an implant in this position. So as you see the contour, that's pretty much similar, which is why you do an immediate in the first place. A few months later, it was uncovered. A PA radiograph was taken just to make sure that nothing is just been going down south. The emergence was seen to be how I exactly wanted it, crown. And that's at the day of the implant placement. You can see the temporary crown. This had quite a wide nasopalatine foramen, so we had to go more towards this side in case you're wondering. That's at the time of the crown fit and an 18-month review. Want to do an annual review and another 2 years. It's been more than 2 years for this case now. but the patient was hospitalized and quite frail, so she can't. She's bedridden basically. But then due to an accident, which she met unfortunately, but then she can't come now. But she's due to come for her 2.5 year review. So every 6 months, what I wanted to follow this case with. So alongside, you can see the canine being replaced there as well. Because it was a missing tooth already, I couldn't use any dentine graft there. I had to resort to a conventional material. Now this is the final outcome. There you go. Quite a good case for me, especially when it was my first case. Another immediate placement, this time the right side. 83-year-old guy, man, rather. Take the tooth out. Just follow the same process. I won't go into much detail with that, but then again, it's exactly the same protocol that I followed. The graft's ready to use. This time, I remember this case where I was working in an upstairs surgery, the suction motor stopped, and I had to just move entire setup in a downstairs room. But alongside what we did was, this is where the staff training came into action, where I left the nurse to do the graft fabrication and I was doing the soft tissue work alongside. And it was quite a bit of a mental chaos, but then yeah, we just somehow got it done. So got the implant placed, got the soft tissue work done. It's all ready to be grafted. Placed the grafting. The occlusion wasn't very favorable, so we just had a healing abutment made just to maintain the contour and have a dedicated emergence later. 4 months later, that's the appearance. Like this part, what seemed otherwise quite a bit bulky there. So the healing was absolutely good there. That's at the time of the exposure. Intraoral scans, and here goes the crown. At 83, this gentleman wanted teeth whitening, so I handed the case back to the principal dentist of the practice because I just do the implant work there. So yeah, he's due to having his whitening and probably some veneer work done. But all in all, it seems to have just worked. It's been quite a while since we did this case. So that's again the radiograph at the time of the placement. Some remodeling of the bone as you would expect here, because it's still, for all you know, an extraction socket. At the time of the crown fit, everything seems to just fall into place. Just give the body some time and it should fall in place. You can see the crestal bone levels there. 1 month review, and now it's been about 9 or 10 months since we did this, but I haven't had a chance to go visit this practice because it's quite far from my routine area. And just to take an x-ray for a review wasn't really the right, so I'll just wait for the annual review. Well, this time we just go a bit posterior and do a ridge preservation. You can see an abscess there and a root treated tooth. Patient did not want a re-RCT and just wanted the tooth out just because of so much pain and discomfort. So we just took the tooth out, our classic Mercedes-Benz cut. Intact furcation, the graft being ready was packed into individual sockets. It was all secured in place with a collagen sponge and with a horizontal cross mattress suture just to hold everything down and let the clot do its action. If you see an x-ray at a 1 year mark, which I've done, you see the homogeneous appearance there. And that was quite reassuring. The ridge width clinically was seeming to be more or less the same. The patient had a gag reflex, so we couldn't place an intraoral mirror in the mouth just to take an occlusal shot, but that's what it looks like. So if you're on the posteriors, one more case where we did the immediate placement, unrestorable tooth, quite a lovely root filling there. Half of the canal was completely filled. Anyway, so we had to take this out. And then again, our classic cut, took the roots out individually. Massive furcation, quite a treat for any implant dentist. You would love to see this. And then the implant osteotomy was done quite correctly buccolingually. Once it was placed, the graft was surrounding the implant, and you can see this appearance there. This is straight after the implant was placed, and then the surrounding socket was grafted with the dentine graft there. And you can see the appearance there. It's not any different from the surrounding alveolar bone. Finished the day with a customized healing abutment. 4 months later, that's the appearance. See, the contour is still maintained again as a part of your immediate placement. No problems in these 4 months in terms of healing or any infection or any loss of stability. As you have your primary stability, you've also got your secondary stability, and that's where the real action takes place. But fortunately, there was nothing wrong in terms of healing. You got the emergence profile, and then that's the radiograph at 4 months, a review appointment after the implant placement. The crown fit was done. 1 month review, the bone still seems okay, but in that 1 month review, generally in terms of radiograph or a clinical appearance, is of particular relevance to me, because if something was to go wrong, I was expecting it in this period, or just generally, if anything has to go wrong, even in a normal implant, it's in the first 2 weeks when the body just dislikes and rejects it. 1 month review being this way was quite reassuring. Did a 1 year review, and now we're close to the 2 year mark, which we will again have a review of, and then just keep on reviewing this, and just to have like a long-term study result with that. So that's the series of cases, different types of cases, and there are many more, but again, more or less, it might just seem to be the same, that it's just that the graft is being put there. So the summary is, in comparison with your synthetic bone materials or your xenograft or your allograft, or even the gold standard for that matter, your dentine graft has got these advantages. So both these materials, the synthetic bone graft and your xenograft and allograft, actually allograft as well. There are some studies which I found show that the allograft is osteoinductive. Some of them show that it's osteoconductive, and also it depends if it is demineralized, freeze dried, and so on. So hence the question mark. So all of these factors which you have in comparison to these biomaterials, the dentine graft is autogenous, biocompatible, prepared easily chairside. The teeth can be used in future. It's got comparable handling properties to these materials, less expensive, and the most important for me is it's better accepted by the patients. There has never ever been a doubt in the patient's mind. Oh yeah, that's my tooth. Cannot be wrong. So after we assess all of this, our take-home message from the entire discussion is the dentine graft is a viable bone substitute material backed with extensive scientific evidence, and it also gives clinical comparable outcomes. It's no less, if not any more. At least it works. So now you've got to be weighing on case selection and the clinical protocols, etc. It has better patient acceptance than other bone substitutes. And then the most important thing, what I find in this entire series of discussion or cases, one particularly from me as a part of my thoughts on this concept, is it is not to undermine the existence of the widely used commercially available materials. It's not to prove that I'm better than you or my technique is better than yours, but it only adds to the surgical armamentarium. And if it is available, it better be used just where the case is right. So it's just one more thing to add to your pot. If we have to see, when I first was thinking of this and actually worked, I was amused. And so if you were to just put this into one picture, and when you just talk to the body or nature, hey, just made a bone out of a tooth, pulled you. And that's similar to what we do in socket shield, or, where you maintain the tooth slither there just to maintain the alveolar bone or the buccal bone and go against the bundle bone theory, or something like an immediate implant. You think that the body doesn't know that it has to now not resorb and maintain the contour and so on. The bundle bone will still resorb. The body will still do what it's got to do. So when you sort of have this to the nature as a body, if the body were to calmly respond to something as naive and juvenile as this, it'll only say, you just realized it now. It was always there. We've just got to unravel this. So with this, I'd like to end my presentation. And I hope it has been insightful in terms of just like an outlook. Excuse me. And if it has been possible, just because of all the mentors that I've had, all the research that we've done, and all the research what everybody else has done, which is why we are here, what we do today. Thank you. And any questions, please feel free to connect. Let's have a chat. Let's have this discussion going on. Thank you very much.
Thank you, Ash. That was really good. It's really insightful. I've heard you speak a little bit about this before, but not to this extent. And it's great to see when we last spoke about it sort of 2 years ago that you're sort of bringing it more into your sort of day-to-day life. If there are any questions, please pop them in the chat. I'll start with a question from Joanna. How do you store extracted teeth for the future? How long can it be stored for, and who or where do you store them?
So, interesting questions. What I've done in the past is tried a few different things. I've just saved it in a normal sterilization pouch. Just for my peace of mind, I actually autoclaved the tooth, because there's nothing wrong in autoclaving a tooth. And then for all you know, if it has to offer, it'll only offer you advantages of just generally. So cleaning the tooth in peroxide, you know how you return the tooth to a patient, you clean the tooth with peroxide and take all the debris, blood and everything around the soft tissues attached and everything, just clean it, make it into a nice tooth. I just went one step further and autoclaved it, and then just vacuum packed it, just kept it, gave it back to the patient, because it might just get lost somewhere in the practice. So just gave it to the patient and then asked them to bring it back a few months later when we were actually going to do that.
Fantastic. I have a question.
Did I answer that question?
Or yeah, no, I think that's fair. Yep.
How long can you save it for? You can actually save it for quite a bit. There's no expiry date for that. Like I was mentioning in the talk, the studies which showed the teeth derived from the cadavers, the fossilized cadavers, so many years later. So yeah, I think if you're just keeping it for some months or a couple of years, that's definitely usable.
And do you have what about sodium hypochlorite as a disinfectant?
Sodium hypochlorite, that's acidic in nature.
Yeah.
So the main concept is to have an alkaline environment. So that is the caustic environment that is detrimental for bacterial growth. So the acidic environment is in fact something that favors the bacterial growth. But then again, obviously it is not to undermine the role of bleach as a thing. It just basically takes away the mineralized component of that part as well because of the acidity of it.
Yeah.
So mainly what we need is an alkaline environment where the bacterial part is just being removed. So when we use the calcium hydroxide into the root canals, we also use sodium hypochlorite as a irrigation material or an irrigant, but we don't use it as a dressing material to leave there in the canals for the bactericidal action to take place. So because calcium hydroxide is similar to sodium hydroxide, it's still, if you're trying to use something, and even if some remnants are left, I would rather have it alkaline as a long-term material rather than having something acidic. So hence not.
I agree. And have you found failure rates, things like that? Have you had many sort of early failures with this sort of material?
Yes, I would be lying if I said no, and I'm glad somebody asked this question. So yes, out of the many cases that I've done, I've found two, probably I would want to call it 2.5, because a part of that was a thing on my side, because I was probably in hindsight a bit complacent about that, because the patient was already on a lot of medication, recently finished a course of antibiotics, and then the procedure lasted quite a bit and I didn't give any antibiotics. So yeah, the position wasn't really good. So that a part of that was, I personally feel, was not to the dentin graft per se, but yes, that case failed. It failed to integrate. Now, if I really have as a comparison to this failure in comparison to any other material that I would have used, just let's keep the dentin graft aside for a second. It's the stability, the position, and I mean that could have happened in any other thing as well. Then I was dejected first when I saw, oh gosh, after doing all of this documenting and all that, this just turned out in the patient's hand in 2 weeks' time. But then a soothing thought was that could have actually happened with any other thing as well. And yes, so that was one of them. And the other two cases which failed were, again, I think it got infected because of the granule size, which was a bit bigger. I didn't do any soft tissue graft in one of the anterior cases that I had done. So the granules had started coming through the buccal gingiva because the phenotype was thin. Once that led, and as a review appointment in 1 week time, when I've removed that, that actually led to a bit of a dent. Like, you know how you have a fenestration, just a small hole. So that actually stayed patent. I was hoping that that'll just get closed. It didn't. And that was a focus of infection. And then a couple of weeks later, I just took an x-ray and that showed a bit of bone loss because there was some more pus coming out from that area. And yeah, in hindsight, I should have either ground it more or probably not taken it out and let the body take its course, or done something on it. But yeah, those couple of cases, yes. So there are failures. So it's not, and obviously it was in my hands. Probably somebody more experienced who've been doing this for a while, it might be lesser, and that's sort of comparable with the other materials as well.
Would you use a membrane?
Not in the need, but yes. So I have used it on a molar case where we were just doing 3 implants in a row. When the threads were exposed, this one was in direct contact with the threads, and then put a collagen membrane over it. You either tack it or suture it, just like your normal xenograft or allograft that you use. Yes, so you can use a membrane if you're doing it like a GBR.
Yeah. So you've said that you normally give antibiotics to the patient after an ADG. What do you prescribe?
So the standard protocol for any implant case, what I do is a pre-op dose of 2 grams of amoxicillin 1 hour before. If it goes on for a while, or maybe I find that it wasn't all that slick a process, we had some intraoperative problems, we just followed up by amoxicillin as a kind of dose 3 times a day for the next 5 days. And if they're allergic to penicillin, I give doxycycline 200 milligrams on the first day and 100 milligrams for the following 6 days. So it's a 1 week course. So that can be done. That yeah, that's just for people who are allergic to amoxicillin. That's the standard thing with or without the dentin graft.
Cool.
So those sides don't change.
No. If there's any more questions for anybody, please pop them in the chat. I'm going to ask a question now, sort of practice owner to practice owner, and we'll brass tacks this. I know that sort of when I buy BioOS, or when my treatment coordinator buys BioOS, I know it's about 130 to 150 plus VAT, something like that.
Yeah, much more.
Yeah. So how much are the Cometa Bio cartridges? How much are those if you're using one per patient?
Right. So
I'm trying to work out it's sort of from the economics of it.
Absolutely, yeah.
Yeah. How many cases do I have to do for it to pay for itself?
Yeah, again, like the previous one, I was hoping somebody would ask about this. So thanks. It was the initial machine, the actual grinder, that is around 1100.
Okay.
So that's your main thing. And then, so that comes with, so when I bought it a while ago, many years ago, so I got it as a deal. So along with that one machine, I got 6 jars and those 6 dishes and about 8 or 10 bottles, the set of bottles free with it as an introductory thing. But now if I go to individually buy just the machine, that's about £1,100. plus
Okay.
VAT. So we're looking at about 1,300 to 1,400 as your initial setup. Now the question for the single-use jars, which are the grinding chambers, so they cost somewhere about £40 each jar, and that's
Okay.
it. So if you were to do, and then obviously you can still charge the patient whatever your normal bone graft charges are in terms of, say, a reduced price as opposed to a BIOS, for example. You can
Mm.
say if that is what you charge. So normally, if I understand the economics correctly, more likely than not, my colleagues charge roughly. So as an associate, you would charge it 3 times. So the actual material cost, say 300, for example, as your pack of BIOS, then which is the expense, then the practice keeps one share and the associate keeps one share. So usually anything is charged like 3 times more. As opposed to that, so on an average, if people charge about 500 to 800 for bone graft, this could be somewhere in the range of about, say, 250 to 300 per bone graft, or maybe 200, whatever. And so if you just do, say, 5 or 6 cases, the machine pays for itself.
Yeah. It's interesting. Interesting. We've been. Do you know anybody that sells the machine, or where you can buy the machine from, and the jars and stuff?
Yeah, so I was in chat with this dealer a while ago because now I've got it all in bulk, so I don't really be in touch with him. But there's this place called Restore Surgical or Restore Medical, that's the website, and then
Mm.
they sell that in the UK.
Yeah.
So
Have
this
you?
gentleman called Robert T. So
Okay.
he sells
Oh,
it.
oh, yeah. Sure, we can find it on a Google search.
Yes, yeah,
Do
should be
you
there.
have you been brave enough to use it in sinus lifting on its own?
For a crystal lift, yes, very, very briefly, but obviously it wasn't really the best
Mm,
case, and it was just not good because then I used the Austin crystal lift, the hydraulic one. Usually for a crystal lift, I don't graft anyway.
no.
Just for a crestal lift. For a lateral one, yes, because there's again quite a lot of evidence for a crestal lift that you don't need to really graft into the thing because it's a blind procedure. You don't really see the membrane in a crestal lift. So if there were to be any micro perforations during the osteotomy preparation where the membrane gets torn, now I'm actually worried that the granule might just go into the antrum and then
Mm.
with the ciliary action maybe block the osteometal complex and so on. So in a crestal one, no. And for a lateral case, I yet haven't found a suitable case. I'm on a lookout for it, definitely.
Fantastic. Well, I look forward to hearing about it.
Yes.
It'll be fascinating. So yeah, you must come back and talk about it. It'd be very
Yeah,
good.
yeah. I would just love to wait for that case where you actually open up science,
Mm,
literally pack that, and maybe you can just be safer because then the granules are obviously not chemically processed in a factory or something where you have a choice of granular sizes that you can actually make it into a paste or something, which is a bit kinder to the membrane. So imagine if the membrane variety is a bit thinner as opposed to a
mm,
thick membrane. Now I'm actually worried. So in my mind, the plan would be just to layer it with a collagen membrane anyway, just to have it as a backup
yeah.
like a shield, and then just put everything, and then yeah, just wait. Really interested in that. Yeah.
Well, we're launching our we were talking before. We're launching our case discussion series again in
Oh,
July.
great.
So we're calling that Implant Platform. So it's for clinicians to come and discuss their cases, ask for
Mhm.
advice and things like that, and
Yeah.
sort of show off what they're doing as well. So once you find that case, you'll have to come along and show us. It'd be very
Please, that'll
good.
be a pleasure. That'll be a pleasure.
We look
That's
forward
great.
to it.
Yeah.
So if there are any questions, we'll start wrapping this up. Just a bit of housekeeping. Our next implant threads will be on Saturday, the 25th of July, and that's with Flavio Pisani from the University of Lancashire. And he is talking 50 Shades of Pink and how to manage soft tissue in daily surgical practice. Flavio is a fantastic gentleman. For those that don't know him, he is a periodontist and he is an implantologist as well. So very much looking forward to that. So I think we'll wrap it up there. So Ash, on behalf of VSS and myself and all the delegates, thank you so very much for coming on board with us today and giving your chat. And I hope everybody's found it really useful. Anybody that wants to watch it again, please go to our YouTube channel and you'll be able to see it there. And yeah, thank you very much. And we hope to see you all on the 25th of July. See you when we see you.
Looking forward. Thank you very much, everybody, for your time. And thank you, John.
You're more than welcome. Take care, everybody. Have a good day. Bye for now.
Bye.